Thank you so much for that introduction, Tammy. I'm going to go ahead and share my screen. So as we were introduced, the goals of today's session are to really talk about the changing landscape of substance use treatment and case management kind of during the pandemic that we've all been going through and even beyond. And so thank you for that wonderful introduction. I'm Lisa Blanchard. I'm the Vice President of Clinical Services. And during the presentation, I'll hand it off to Rachel Carroll, who is our Clinical Care Manager, and can really talk about the context of trying to do this work with high-risk populations in a case management program. So the objectives of the presentation are really to describe substance use disorders, the system of care, and what current substance use trends we're seeing. Depending on your role in the work that you do, some of this may be information you already have, or it may not be, but it's really helpful to help make sure that everybody has kind of the same understanding of substance use disorders, what all the levels of care are, and then of course what we're seeing in addiction treatment on current substance use trends. Identify the impact of the pandemic on substance use treatment and case management, and then apply that knowledge to individual real life cases to improve outcomes, which Rachel will do a wonderful job of giving us a couple of examples. And we welcome kind of feedback from the group on cases you may have seen in the question and answer portion. We welcome questions throughout, so please feel free to type those in as they come up. So I'm going to start with really that basic understanding of understanding substance use disorders, what recovery is, and what the system of care looks like today. And so I want to start with inpatient, right? The most acute system of care for addiction, and acute treatment services now being shifted in language, as there's always some language shifts happening in the addiction and recovery world, to withdrawal management. But that's really what many of us know as inpatient detox, right? Detoxification. That's when we need to have some medical monitoring of withdrawal symptoms. So therefore, substances that require that monitoring, whether that be alcohol, benzodiazepines, or opiates. And typical length of stay is about 5 to 7 days. Individuals that require this level of care need that medical monitoring, right? So typically are using daily. In access can be challenging, especially during this pandemic, where there have been lots of shifts in beds, across New England. But typically, you call the program, check for availability, and you may have to call back or coordinate kind of a time when there may be a bed available. But that regular, frequent check-in is really helpful at that level of care because of that 5 to 7 turnover time. There's often turnover in beds. And in Massachusetts, there's also transitional support services, which is often called a holding. And that's a short-term residential structured environment and support services, often used in a transition from those ATS beds to kind of the next step, whether that's residential, outpatient, other aftercare like sober homes, kind of waiting for a placement, but still able to provide some structured care during that period of time. Typical length of stay is about 2 to 4 weeks. But it could be more, right? Because it's a holding. If there are bottlenecks or challenges with accessing the next step for someone, they can remain in a TSS transitional space for a while. And so often that's because of that slow turnover and wait for longer term beds. And then there's also clinical stabilization, which is ASIM level 3.5. And that's for folks who may have post-acute withdrawal. And you can admit directly from the community or step down maybe from a detoxification. So that's appropriate for somebody who maybe is on medications, and we'll talk a little bit about medications for opiate use disorder today, or medications for alcohol use disorder, have maybe not daily use that requires detoxification, or may need kind of stabilization, particularly for stimulant use disorders. And especially we'll talk a little bit about trends in seeing a rise in methamphetamine use. So these folks usually need an intensive clinical monitoring, about 2 to 4 weeks average length of stay, but very individualized. Often it's challenging to access this level of care because there's a significant demand for it. But you can refer directly from the community, from a hospital to a CSS, or a step down from any other program, or a step up from outpatient for someone who may need additional stabilization. And the residential system, it has a lot more variability as well. So it's often a structured residential system, but the length of stay is going to vary based on the individual, but also on the structure of the program. So it could be, you know, a 3-month residential, a 6 to 9 month, a year-long residential. And because that turnover is not as frequent, they could often be wait lists, you know, due to that kind of bottleneck of having less turnover. And so you might need to check in kind of more frequently to indicate continued, you know, need and interest on that wait list. And there's several different types of residential, and it's just helpful if you're helping place someone into, you know, addiction residential care, to ask about what those types of residential are, to see what might be the best fit. There's just kind of more clinically focused residential treatment, often have a lot of group treatment and individual counseling embedded. Recovery homes are often structured settings for those in recovery, where the residents kind of become part of a community, but also go out into the community and use community resources, self-help groups, and employment. A social model program is really a sober living setting with a lot of peer counseling and case management. And residents provide each other with a culture of recovery, support, and role modeling. And often residents are out in the community, whether that's working, you know, pursuing education or volunteering. And then a really structured residential is called a therapeutic community. And that's residential treatment in a very structured setting where the residents take an active role in their treatment kind of as a group, as a community, and help the individuals take responsibility and become positive role models. So it's helpful to know, if referring into residential treatment, what might be a good fit for someone. If someone's not looking for that level of structure of a therapeutic community, you know, you might want to not make that referral because you want somebody to be successful in their recovery pathway. Often individuals may, you know, do well in a correctional, stepping down from a correctional setting. Oh, and I see a chat that my audio might be off. Hopefully that's just the internet and the universe that we all live in, which is part of one of the challenges, right, that we're going to talk about in the pandemic. So please feel free to let me know if that doesn't resolve. I'm going to shift to talk a little bit about the outpatient levels of care. And so often some of these titles will be used interchangeably, but there's intensive outpatient, partial hospital programs, sometimes structured outpatient addiction programs. And so often that could be referred to as day treatment as well. And so that frequency of how often, you know, folks come in for that kind of intensive outpatient service could be, you know, 3+ times a week, or it could be every day for 5 days during the week, and it might reduce kind of over time. You know, depending on the program structure, it may be included or be concurrent with mental health treatment. So sometimes a really helpful stabilization outpatient for somebody who's trying to stabilize their mental health symptoms at the same time as stabilize addiction. Often it's 2 to 4 week length of stay, but if it's a staggered time frame where somebody's coming for 5 days, then 3, then reducing it, it might be a bit longer. And usually you have to call the program and get some kind of a screening, whether it's a screening assessment or a screening meeting before you start those groups. Outpatient counseling is really probably the most variable, right? So it's very much dependent on need, but also on the clinician's schedule, on the patient's or client, I'll use those interchangeably, willingness to attend or availability to attend. It includes some combination of either individual, group counseling, family counseling, or all of those, and could be included or concurrent with mental health treatment. And same thing, you would want to call and schedule an assessment to begin outpatient. Many outpatient programs now offer walk-in access or kind of immediate access, as we do as an organization. But of course, especially with the impact of the pandemic, some of those admission procedures may have shifted slightly. And then we're going to talk a little bit about medication treatment kind of later on in this presentation, but that's a component that could be included with, it should be included with outpatient counseling, may be done in conjunction with intensive outpatient, or even provided while somebody is at some of those mid-level inpatient settings. But how the approach is done with medication treatment may vary very much by the program and by the medication. But the consistent theme is that medication is used as a tool, right? It's used as a tool to manage withdrawal for some of the medications, manage cravings, and it's most effective when offered with outpatient counseling and clinical components. And again, there may be walk-in admissions or scheduled admissions. It's going to depend on the program. So those are the levels of care that are available in the addiction treatment system now. They're often decided by ASAM level of care criteria, but also availability and patient preference. So that's often a combination of what level of care you refer someone to is a mix of what they could benefit from, what they might really need for structure, but also what the patient is willing to do. I do want to talk a little bit about a couple of case management roles, and then I'll turn it over to Rachel to dive in a little deeper on the program that she oversees. And so some of these are newer roles to the field. It might have, depending on the state that you're in, the payers that you work with, the population you have might have slightly different titles, but there's a recovery support navigator, and that's exactly what the title suggests, right? It's someone to help the individual navigate recovery, right? Navigate the treatment system. In Massachusetts, it's available, for Medicaid patients, and is starting to become available for commercially insured individuals and private payers. But it's really that care management and system navigation for those that have a diagnosis of substance use disorders or co-occurring mental health disorders. And the purpose is really to engage people, right? To connect with individuals wherever they present in the treatment system and support them in continuing that recovery pathway. So whether that's transition from, say, a detox stay to outpatient, or help support someone who's in an outpatient setting who might need some more structure or might need some access to community resources to avoid having to go to a higher level of care. A recovery coach is a little bit different, right? That's a more of a peer role. So that's a non-clinical support service, often provided in treatment programs and outpatient settings or in other treatment programs, in hospitals, emergency departments, or in other community settings. And that kind of support is provided by individuals who are currently in recovery. Right, so it is defined by support from someone with lived experience with addiction and or co-occurring mental health disorders that has been trained to help their peers with a similar experience to gain hope, explore recovery, and achieve life goals. Coaches are actively engaged in their own personal recovery and share real-world knowledge and experience to support individuals in obtaining and maintaining recovery. So I'll often describe, RSN and other case management roles different from recovery coaching, and that a peer or recovery coach is coming from that place of lived experience, not to share their direct story per se, but to provide that hope and kind of walk alongside someone as they work on their recovery journey versus helping them directly navigate for the person, which is often what we're doing in other case management roles. And now I'll turn it over to Rachel Carroll, who we introduced in the beginning, but she'll talk a little bit about the program she works in.
Thanks, Lisa. Just first and foremost, I might be dealing with unstable internet myself over here, so I'm going to try and speak slowly and clearly so everyone can hear me. If there's a severe lag or anything, please let me know. And if I end up disconnecting for any reason, Lisa will just pick up where I left off. So yes, thank you. I work for one of the community partnership programs in Massachusetts, the Behavioral Health Partners of Metro West. Many of you may be familiar. I think these are popping up in other states, but the Behavioral Health Partners of Metro West is a CP program. Mass Health has identified us and has identified clients that they wanted referred to us because they may be high utilizers of inappropriate levels of care. So things like high utilizing the and our role is to try and reach out to them and connect them to more stable services, as well as to try and bridge the gap that we know exists between the medical system, the behavioral health system, and substance use disorders. We're aiming to really make sure that any provider on a person's care team knows of the other. So the way that we do that, we get these referrals from Mass Health. We actively outreach these patients in a variety of ways, by calling them, texting them, emailing them, sending them letters, at times when it's appropriate, even knocking on their door to introduce ourselves and our services. When a person agrees to participate, we complete a comprehensive health assessment with them and then generate a person-centered treatment plan. This includes all types of health goals, to include medical, mental health, substance use disorder, and also things related to social determinants of health. So food insecurity, housing insecurity, things of that nature. Then after we get that treatment plan completed, we try and help carry out those goals with that person. We aim to connect them to the appropriate level of care or to the appropriate community resource that they need to create overall health and wellness for themselves. That is identifying care teams for them, new care team members if they don't have them, or facilitating communication between and amongst care team members that might already exist. We assist clients with care transitions. So as Lisa kind of mentioned, it's similar to a recovery support navigator in a sense where we do work in detoxes to connect them or transition them to an outpatient level of care for substance use, but we also go into emergency rooms and try and connect them back to their PCP or things like that. We do health and wellness coaching. We want to teach everyone how to be well and utilize the appropriate level of care or community resource that is best suitable for them. And we also just make sure we are showing them how to connect and navigate the community that they're in. And I'll pass it back to Lisa.
Thank you, Rachel. So I'm going to shift just a bit. So we've talked about kind of what services are available, what the system of care looks like, and where kinds of opportunities for case management exist within individuals with addiction. And so I want to just talk broadly about how people recover. And provide some education on that. So, there's on the left side here, some people just work towards natural recovery, right? Not often those we're interfacing with in intensive case management and in case management roles, but it does happen. Sometimes people just have a shift of desires, their values, they change their decision-making, they reduce risks. That's often the college student, right? Who maybe experimented with a lot of substances, was binge drinking quite a bit in college, but gets it together, finishes their degree, and then kind of gets a job and stops that behavior, right? So that's, again, not often the folks we're talking about, but it is possible. There's also supported recovery, and that could be family interventions, right? A spouse, a family member, somebody getting involved and saying, we are concerned about you. We think you should make a change. Similarly, legal or work sanctions, the threat of potentially losing your job or having kind of probation or other legal sanctions to mandate some intervention, and, mandated treatment at times can work. Brief counseling interventions in a PCP's office or otherwise, and of course, mutual help groups like 12-Step or other self-help support groups that have been around for a long time can be used to help people work towards recovery either by itself or in conjunction with formal treatment. And so the goals of formal treatment are really to address the fact that substance use disorders, are a chronic brain disease. Right. So, working in the case management field, we're kind of used to kind of learning about chronic diseases and things that kind of have a chronicity to them, like diabetes and, asthma and hypertension. We need to be looking at addiction in very similar ways and seeing addiction as it is and not a moral failure. failing, but seeing it as a chronic brain disease because of the way substances impact your brain. And so what formal treatment does is really allow that change in your brain to happen, right? Facilitate those neurochemical changes, manage kind of the relapse remitting course, that cycle that is often really, really common, reduce the significant health and social consequences. And the goals of treatment are just to shorten that impact, right? Have substance use really impact the individual and the community less, reduce harm, so keep people safe, while they're, working towards recovery. We can't treat an empty chair, and we are unfortunately losing people every day, which I'll talk a little bit about today. And of course, the goal is to achieve recovery and sustain recovery. And I want to provide some education about the types of treatment and where medication fits in. So often it's really helpful to kind of start looking at, okay, what are the behavioral treatments, right? I'm a licensed mental health counselor. And so what I'm doing typically is on the left side of this screen, right, is working in individual or group counseling on helping individuals enhance their motivation for change, because how many of us change because somebody told us to, right? We have to find our own reasons for wanting to make a change. And then once we've enhanced that, improve skills for making a change, right? Often people just don't have the skills to make changes, but also teach relapse prevention skills and do cognitive behavioral therapy, which really helps anticipate the triggers and halt that cycle of conditioned behaviors and help people understand how their thoughts and feelings are associated with use and develop more healthy coping skills. And then do things like help restructure social environments, which have a lot to do with patterns of use, and encourage pro-social activities. The role of medication is really there to stabilize those neurochemical imbalances, right? So relieve symptoms of withdrawal. Withdrawal is really unpleasant and really does drive use patterns. And so if we don't treat that withdrawal, sometimes we have a very difficult time getting somebody to a place where they're able to change their use and decrease craving, because the power of our brain is pretty strong, and cravings are very, very strong. But also to prevent intoxication and overdose, right? If we're losing people, we lose that opportunity to help them work towards recovery. But if people are feeling better, right? If we're giving them, medications to make their bodies feel better, it gives the brain a chance to repair, right? And develop new pathways. So part of what medication treatment can help support is facilitating that neural repair and restructure. And the piece that often people don't think about with medication treatment is that it actually helps improve engagement and retention on the left side of the screen, right? So if you're giving somebody medication that's really helping them feel better, getting them to come in every day because they feel better when they take the medication, that's more time that you have in front of a nurse, in front of a counselor, connection to groups and individual counseling and the staff in the program. And so it kind of pulls people in enough to connect them to care so they can work on the left side here in that behavior change. And so they're really effective tools, but not definitive cures. And they're really designed to be used with other treatment modalities, kind of not on their own. Although there's lots of evidence that providing medication, even by itself, is better than providing nothing, right? Because we're going to keep people alive and feeling better. So I want to just talk a little bit about the differences between the medications. And so I'll start with methadone, right? So methadone's been around the longest. It's studied for over 40 years, one of the most evidence-based practices for opiate use disorder. And it has a bit of a stigma associated because it is an opiate. But it's a long-acting opiate agonist. And the difference between methadone and other opiates is that long-acting piece, right? And so if you've ever had your teeth pulled or have had an acute injury and have had to take opiates to manage that pain, you know that they don't last that long, right? It's like every 4 to 6 hours, and you need to take more or you're going to be in pain. Well, when somebody has an opiate use disorder, they need to keep taking something regularly in order to stop that withdrawal symptoms that come after use. And so what methadone does is it lasts a lot longer. So it lasts 24 or more hours. So you can dose that once a day, and it functions to relieve those symptoms of withdrawal and protect someone from withdrawal for that full day. Low doses are going to relieve that withdrawal. Moderate doses are going to reduce craving, and high doses, although this is more challenging with fentanyl, can block the effects of using opiates. And buprenorphine has been around for many years now, although not nearly as long as methadone. And it is also an opiate, but it's a partial agonist. So what that means is it activates the opiate receptors in the brain to a much lesser degree than a full agonist, like methadone or oxycodone. It is able to be prescribed in a flexible office-based treatment because it has a ceiling effect. So where you can give more and more methadone to manage withdrawal for somebody who has significant use patterns and might not feel withdrawal at the dose that they're at, you can increase and increase methadone until they get to a place where they're feeling relief from withdrawal. For buprenorphine, you can't give more and more and more, it levels off. So that has some safety built into it, which makes it, allowed to be prescribed in an office, right? In a primary care's office, in an addiction specialist's office, now often in emergency departments. It's just a little bit more flexible. So that can be really helpful for folks who can't come to a program every day where you have to present daily for methadone treatment, but you can still receive medication to manage addiction. Patients also, because it's a prescription, control dosing times, which is not always therapeutic depending on where somebody is in their recovery path, right? If you can choose to take a medication or choose not to. And so sometimes it's the timing of when that is a good treatment intervention for somebody that can be helpful. And it's mixed most often with naloxone, which is Narcan, to prevent abuse. So you take buprenorphine sublingually under your tongue, and if you take it appropriately, the naloxone Narcan is not absorbed. But if you were to try to take it inappropriately, snort it, inject it, use it in another way, the Narcan is activated and it puts you into precipitated withdrawal, which nobody wants to do, right? That's not the goal of anybody when using substances. And then there's naltrexone, which many people will kind of view because of stigma against using an opiate agonist or partial agonist, for treatment, because it's not an opiate, right? It's an opiate receptor blocker. So it binds tightly to those opiate receptors, so no opiates can get in when you're on that medication. It's available for oral and monthly injectable forms, and approved for both opiate and alcohol addiction. In fact, it's probably the most effective treatment for alcohol use disorders, what this medication started with. But the challenge with the medication, although we need all of those tools, and it can be a very helpful medication for many people, it does not impact withdrawal. So you also need 10 to 14 days without an opiate in order to take it, or it's going to kick all those opiates out and put you into withdrawal. And so that's not a good way to start a medication. So often individuals who are opiate dependent in communities can't put 10 to 14 days together. And so, may be a more appropriate kind of following an inpatient stay in one of those levels of care that I described earlier, or even step down from incarceration. And I mentioned, just briefly, medications for the treatment of alcohol. There's a few things out there. Camprol, a camprostate, has been around, for a long time. You dose it 3 times daily after you can put together 7 days. So maybe after a detox day. But you don't stop it if somebody does relapse on alcohol. Again, naltrexone is that opiate receptor antagonist, but it really is one of the most effective treatments for alcohol, and really does it blocks the euphoric effects of drinking, and is thought to help support kind of craving for alcohol. But the challenge is you really can't take opiate medication when taking that. So whether it's because you have concurrent opiate use disorder and alcohol use disorder, or chronic pain or other things, might rule out naltrexone as an option. And there's also disulfiram, which is antabuse, not widely used, but still available. That's that alcohol sensitizing agent that really makes you very sick if you were to drink. But really the message here is that in order to combat this chronic disease, we need all of the tools, right? All of the pathways. And people need to be given access to kind of whatever pathway they're willing to try and support through that process. And so I've talked a lot about recovery. Recovery is absolutely possible. I'm probably going to spend a couple of minutes, talking about what is really challenging out there. And if you're interfacing with addiction, the addiction treatment population or individuals with substance use disorders, this is probably pretty familiar to you. But really the recent trends are that these, what you can call novel psychoactives, are really what's available. It's actually quite rare in our treatment programs to have anybody positive for heroin anymore. It's almost always fentanyl because that's what's available, and what's available in the communities really does drive use patterns. So these synthetic drugs are increasingly available online, on the street, less expensive, accessible, attractive for their ability to provide the euphoric effects that people are looking for. And new substances and slight variations are constantly being developed and disseminated. So it makes it hard to track use and the impact. Even the DEA has a hard time kind of tracking what is out there, let alone treatment providers, case management staff, and certainly let alone the patient population. And these newer drugs mimic the effects of commonly used substances. So you can see for opiates, fentanyl and fentanyl, stimulants, methamphetamine, which I'll talk about, hallucinogens, it's going to be, methadone, bath salts, those kinds of things. And cannabis, although more widely used because of how more prevalently legal it is, there's still quite a bit of K2 and spice and CBD oil, things that are not regulated, available. And these infographics are a little old, but they're so accurate, right? So we did a lot of work as a society to really minimize the impact of the pharmaceutical overprescribing of opiates, which, if you've seen any of the documentaries, had quite a bit to do with the opiate epidemic, right? So it took us a while, but we did a really good job of managing that. Prescription drug monitoring programs, prescribing limits, all of those things really did curb prescription drug use. But you definitely feel like we were out of the frying pan and into the fryer because then fentanyl showed up. And that's so much more potent, right? So you can see the deaths related to synthetic opiates are extremely high. And it's 50 to 100 times more potent than morphine. And even this picture, right, for those of us that are really visual, just seeing how much heroin it takes to equal how much fentanyl and how much carfentanil, you can see why this is such a high risk, medication and high-risk drug out there. So really having overdose prevention conversations with the individuals you're interfacing with is vital, because I've been doing this work for over 22 years, and the last several years it's really changed in that every time somebody has a return to use, it could equal death, right? It could, whether somebody is on maintenance medication therapy or not, whether they have really significant recovery, sometimes that happens, right? The pandemic is very stressful, life events happen. People may have just, even if it's a brief return to use, and because of how high risk the substances are, even a brief return to use could equal overdose. And so making sure that people are really aware of that and have really good overdose prevention strategies available, calling people, all of those things. And I'll talk a little bit about that, in the impact of the pandemic. I also just want to note the methamphetamine rise. And so, in New England, it took us a bit to see this, right? Like we'd hear about it in other parts of the country, movies being made about it. And, we still were just predominantly dealing with, opiate use disorder. Unfortunately, that has changed, right? There's a significant rise in stimulant deaths, both cocaine and methamphetamine. Deaths increased by 34% for cocaine and 33% for psychostimulants. And what's behind that, right? And methamphetamine doesn't often equal death, right? There's some cardiac concern, stimulants can cause cardiac concern. There's things that can happen, but it doesn't stop your breathing. It doesn't impact your central nervous system the way that opiates do. So what is going on with these overdose deaths related to stimulants? And it's really that methamphetamines are on the rise nationally and now here in New England, and co-use and polysubstance use is the norm. right? So we're seeing, a lot more polysubstance use where people are using opiates and stimulants. And so you'll see both that we're seeing that kind of even in drug seizures and in overdose death toxicology. And it really is that kind of what's available in communities is what drives use patterns, and the same, substance use, the same drug dealers are dealing both opiates and stimulants and kind of helping contribute to a polysubstance challenge, nationally. And the last trend I want to talk a little bit about, because I think it's so important to the work that we all do, and we really have to recognize it, is that there are racial inequities, right? Opiate-related overdose deaths have been rising significantly even before the pandemic, and there have been clear differences with race and ethnicity, with Black communities rising much faster. And that COVID-19 impact really, increased existing inequities in our healthcare systems, and stigma plays a significant role, right? And so individuals, in the Black community with substance use disorders are doubly stigmatized by their minority status and their substance use disorder. And we know that stigma really does impact use patterns, and that addiction cycle can continue. And so really, as a treatment field, we need to recognize this, and we need to make sure we're adjusting our care, adjusting our case management services. There's a lack of culture responsive and respectful care that provides challenges. And even studies have shown, right, that there's differences. I went over the 3 different medications that are available, that particularly Black patients in the United States were less likely to receive buprenorphine, which has that flexibility and accessibility of being able to take a prescription home, and more likely to be referred to methadone, where they have to come in every single day. And we know in our treatment settings that although the overdose rates are much higher in these communities, we're not seeing those rates in our treatment settings. So we as a community really do need to take a look at the whys and address that. So I've been including this kind of really in every presentation that I've been doing to raise awareness. So I want to shift to this impact of the pandemic, right? So that's all the trends we were seeing long before the pandemic, the treatment system as it exists, and how we've had to change the treatment system, and what the long-term impact of the pandemic has been on substance use treatment. And then Rachel will talk quite a bit about her experience in providing case management services. So we'll talk about telehealth, right? Telehealth is the topic that we're all talking about. We all had to quickly learn how to do telehealth. Some of your communities may have already been doing that, in rural communities in Maine and other locations, but in Massachusetts and in other New England areas, it really wasn't as common. And so we all had to completely shift our practice. And so Spectrum did the same thing. We had to utilize video telehealth, but also, fortunately, we've been able to provide services via telephone, and that's been extended, for at least for now, and do that both with individual and group sessions, right? So, there's the infographic of somebody doing a session, in a cartoon, but also, the ability to do a group session, with both kind of video and telephonically. And even in our inpatient settings, we've had to create a telehealth environment for safety and distancing. But one of the things we've definitely had to do is really focus our clinical content on the most relevant topics right now, especially that overdose prevention that I talked about, and aftercare planning. But in those inpatient levels of care, and Spectrum offers most every one of those inpatient levels of care, it's really hard to follow, pandemic guidelines. It's what we call congregate care, right? So everybody is in shared living spaces, shared rooms, shared bathrooms, not really lending itself to social distancing. So we had to really think about how do we still provide adequate care, but keep people as separate as we can for safety. Things like reducing group sizes, so reducing the volume of groups, or offering multiple smaller groups so people could spread out, as much as we could. The winters are obviously tough for that, especially in New England winters, but whenever we can, do outside treatment, right? Utilize outdoor rec spaces to do individual group family sessions in order to increase safety. But probably the biggest response that we as an organization have had is to develop a COVID unit. And so we were fortunate that we had space in one of our inpatient buildings that was very isolated, right? Separate long hallways, separate exits, entrances, and we were able to create an isolated withdrawal management, detox, and clinical stabilization unit for individuals who are positive for COVID, but also concurrently needed addiction treatment, right? But didn't need hospital level of care because we know how overburdened that system has become, in the past year and a half. And so what we have done is provide their entire service via tablets. Right? Like obviously, like there was nurse check-in and medication dispensing with full PPE. You can see an example in this picture of the full PPE that is provided. But all the clinical services, we gave everybody a tablet, right? And they could utilize video telehealth like DoxyMe to communicate for assessments and counseling sessions, but also, it's a long day kind of sitting by yourself in a room. So preloading clinical materials in that tablet and direct links to those online self-help meetings and mutual support meetings that have been vital to the addiction recovery system during this pandemic. Just a few substance use, treatment considerations, recognizing that when we're doing telehealth, typical monitoring is reduced, right? We're not putting eyes directly on people as often. So that might require us to do more frequent clinical contact, really encouraging the use of video whenever we can, right? Because at least gives us a lens and a view into their world, and increased monitoring. Just a recognition that social isolation is really challenging, right? Addiction thrives in isolation and recovery thrives in connection. So trying to find that connectedness wherever we can, but realizing that isolation, it doesn't just perpetuate addiction, it's also dangerous, right? Because if you are using alone and have an overdose event, it might be more difficult to respond to you, right? You can't administer yourself Narcan. So, using things like making sure there's Narcan available, let someone know if you're using, and if you can't, utilize kind of technology. There's apps and phone lines that can alert someone if you're using and you don't respond, and then dispatch kind of emergency services. And so now I'm going to turn it over to Rachel to talk about kind of the similar impact on the case management services and how you've had to adjust those.
Yeah, so with our program, as we mentioned, we're community-based work. So in 2018 and 2019, when we were really getting off the ground, we were such an additional support to the levels of care that Lisa was just talking about. Inpatient levels of care like detox and residential, outpatient, where methadone maintenance or buprenorphine are prescribed. Here we are in the community really getting to kind of fill in those gaps with folks and meet them where they're at. So 2018, 2019, we were hiring care coordinators and we're telling them your office for that day is your computer, your cell phone, and wherever your client needs you. Could be their home, could be a park bench, could be a coffee shop. So, we got to really see people and support people in the community in which they were living in, which really helped us when we were doing those things I mentioned earlier, generating an assessment and a treatment plan for these people. We really got to see what elements of their life needed assistance. So pre-pandemic, we were the true essence of a community-based program, meeting people exactly where they are in the community and connecting them to all of the available services to support them. In comes 2020 and our lockdown. So the lockdown specific portion of the pandemic was really challenging. Obviously, many of you who might be in this case management role or care coordination role felt this effect. We're a community-based program and now we're no longer allowed to go into the community to meet these folks. So we're telehealth just like everybody else. The real big issue with the population that we serve is that we're not necessarily in our program working with middle or upper class folks who had sophisticated access to the internet, to computers, or to even smartphones with things like FaceTime. We were working with folks who, because of the demographic, Medicaid, mass health population, were often disenfranchised with housing insecurities, food insecurities, as I mentioned, and perhaps used government phones who only had limited number of minutes or text messages that they could send per month. So, it was the challenge just to connect to the clientele that we were serving based on the fact that we were locked down. The second challenge really was then, if we did connect with these folks, trying to connect them to the services in the community, because all of those things had changed as well. As we know, PCP offices were either closed or transitioned entirely to telehealth. Elective procedures were canceled. Things like AA and NA, you know, things that really supported our clients, or going to the gym, church services, the things that we built recovery on were pulled out from underneath people. So it really made our role as a community-based support to clients very challenging and very limited. We did the best we could to increase contact with all of our clients, all of our enrollees, paying special attention to the people with mental health or substance use diagnoses, because as Lisa mentioned, isolation and being alone are high-risk situations for people in recovery or dealing with mental health issues. And we had to do the best with what we could to create this connection. And we'll talk about some case examples later where we actually, I think, did a pretty successful job at this. It was a challenge, but this was the toughest part, being a community-based program and really having to try and do community-based work using only telehealth services with a population that did not have sufficient access to this stuff. And now as we're transitioning to I don't want to say post-pandemic, post-lockdown, things are reopening, which is wonderful. So we're able to reconnect people back to things like their PCP. We're able to start getting folks back to AA and NA meetings. But the other issues, we've always, if you've been in this field for a while, you know that there's always been some disproportion to the folks who need a mental health or substance use service and what is actually available in society. We've always had a challenge finding open detox beds or psych prescribers for folks who might need it. But since the pandemic, I think we've seen a lot bigger of a disproportion, a lot bigger gap between people who are needing services and what is actually available to them. Obviously, during the pandemic, there was an increase in substance use disorders, either those who already had one, or there was new and emerging substance use, as well as new and emerging mental health disorders. So finding providers right now as case managers and care coordinators is a challenge. And also in one area we haven't seen it before, but we are seeing it now, especially in the Northeast. You know, New England is known for its medical care, but right now we're also seeing a shortage in PCPs. So we're also challenged with getting folks who did miss those well visits last year, or who do need elective procedures last year, either getting them reconnected to a provider that they already have. Many of our appointments are booked out now until June of 2022, or establishing a relationship with a new provider for those who are coming to us and don't have a PCP. So the post-lockdown challenge as care coordinators, typically we're supposed to receive this patient and pass them on and connect them to the appropriate level of care, not really holding on to them for very long. But right now, because we're passing them on and they're coming back, trying to refer them to a PCP, we're getting resistance. What we're challenged with, I think, is making sure that the clinical staff, like myself, the RN staff on our team, are able to support our staff as well as the clients we're serving while we work to connect them to the appropriate levels of care. We're really hopeful that in the coming months, the medical and mental health system will pick back up and we'll be able to connect these people to the appropriate services that they need. Moving right along, I know that I briefly touched on this before. I'm going to get into some data that shows the utilization of the emergency room in the hospitals for folks. What I wanted to touch on quickly, though, is just the percentage of people that have a substance use disorder and a mental health disorder that we treat, because the following data that we're going to show does not reflect any hospital utilization for a substance use issue or for a mental health issue. Due to 42 CFR HIPAA code for Massachusetts, we're unable to receive that information for our clients. We are able to receive medical information, however. So I did want to highlight there is such a huge percentage of our census that we're working to get data on as far as utilizing the ED for a mental health or for a substance use service. We don't have that yet, but yeah, 70 to 75% of the folks on our caseload have a substance use disorder, and therefore a goal on their treatment plan that they're working on, and 60% of our census has a mental health disorder and a goal on their treatment plan that they are working on. So anywhere between 25 and 40% of our population could be using the ED or detox at any given time to treat one of these issues, and we are not being notified of that, at least when they present at the ED. Later, through qualitative information, we're able to obtain that, but right away we do not receive that. What we do receive are patient ping. Some of you, again, may be familiar with this, and for those who aren't, ping is basically a way for us to be notified in real time that a person presents to the ED. Their insurance is billed, and through patient ping, we're communicated about that admission. And so what I wanted to highlight was the impact on folks utilizing the emergency room or being hospitalized between June and August of 2020 and between June and August of this year. We got a little more sophisticated with our data breakdown this year, so we were able to separate the data from ER visits to a hospital admission, where last year we did not do that. So I'll do my best to summarize it so it makes sense for everybody. But last year in June, we had 123 pings, hospital pings, again, either combination of someone presenting to the ED or being admitted, on 70 people. So that means 70 people presented a total of 123 times in the month of June. 105 people presented a total of 262 times in July, and 50 people presented 69 times in August of last year. This year, June, we add the two numbers together. We're still lower than last year, a total of 95. July this year, total of 148. And August of this year, a total of 129. So we definitely saw a surge in August of this year. But what we really attributed to the number of pings soaring last summer was really what I mentioned before, the lack of accessibility to the appropriate level of care, to a PCP, to a therapist. Many of these things were closed or difficult for this population to access. And so the next best thing was the ER. The other element I did not mention is folks who were homeless. The just stay home, COVID slogan we all used last year was wonderful for any middle or upper class person who had all their safety and medical and wellness needs met at home. But for most of our population, they did not. So when everything else was closed, they had to turn to the ED, which is, of course, an inappropriate level of care for boarding, but it was just all that was available. So that is what we looked at the admissions around this time of last year. Obviously, slightly decreased this year. We're hoping to continue the decrease moving forward. So that's our data, and I think we're moving right on to a case example. So this is the one, I don't know, I'll definitely do this one, Lisa, and if we want to jump into questions after, we can skip the second, whatever you think is appropriate. But I think this one really highlights what we had to do during the pandemic to provide care coordination to our patients. So Peter is a 43-year-old male who was living alone in an apartment in Northeast Massachusetts. He was referred to us during the lockdown portion of the pandemic. Peter only had access to a government-issued phone and no other forms of technology. At the time of referral, the only other care team member Peter was working with was a VNA who reported to Peter's home each morning to administer medication. Peter reported having found his girlfriend deceased from an OD in their bathroom 90 days prior to being referred to us, and reported that he was self-medicating his thoughts about this by drinking 1 pint of whiskey every day. Peter's depression and trauma was so significant, it took multiple weeks of peer support specialists on our team and his assigned care coordinator to communicate with him solely over the phone and build rapport and trust. Approximately 1 month into our work with him, he agreed to go into detox for treatment. At that moment in time, however, there were no open beds available at any of the local detoxes. Because he continued to drink daily, Peter and his assigned care coordinator agreed to a safety plan of us calling him twice per day, once while the VNA was present in the morning, so all the care team members could communicate about any concerns together, and once at 5 p.m. to make sure he was okay for the evening. Peter agreed that if we did not hear from him within 20 minutes of either phone call, the police would be called to complete a wellness check. Peter graciously agreed to this plan and followed through with it for approximately 1.5 weeks until the detox placement opened up in Spectrum. While he sought treatment in Spectrum, the assigned care coordinator and care specialists were able to communicate regularly with the detox staff about Peter's status and his discharge plan. Upon discharge, Peter admitted that being in detox helped him feel less alone in his grief and with his alcohol use. He returned home with increased VNA services and a schedule of AA meetings that he could call into for support. He was also open at that time to speaking with a therapist. So even over the phone, we never met Peter face to face during his time with us. Never saw him. He never met his care coordinator. But we were able to still support someone who I think would have otherwise been in terrible distress throughout the lockdown.
Yeah, I think it is helpful to go over the other case example, and then we can open it up to questions or what individuals in the audience might be seeing in their work. So yeah, let's go on to Melanie.
Sure, thank you. So this is an example of pre-lockdown care coordination. Melanie was referred to us in October of 2019. She is HIV positive and in active, sustained recovery from opioids as an MOUD patient at Spectrum Health Systems. Melanie was referred as an established patient with the local health center to include a community health worker. That's a person at the health center who helps communicate with the providers at the health center. So she was helpful with scheduling appointments, etc. Melanie also had a PCP and specialists on the Ryan White treatment team. In March of 2020, just before the pandemic hit, the community health worker reached out to our team to alert us that Melanie had been missing very important appointments. The community health worker decided it would be best to call a meeting with all of her providers for a meet and greet and to ensure that each of us knew the role of the other in Melanie's care. On March 10th, 2020, Melanie, her care coordinator, her PCP, and one of the specialists on the Ryan White team met together at the health center office. Melanie shared at this meeting the reason she continued to miss appointments was because she often did not know she would need to be at the health center for hours, and she did not have a car to bring herself to and from. So it would create scheduling issues for booking transportation. The providers listened to her concerns, and a plan was created to ensure that Melanie knew how much time she would need to set aside for each appointment so she could plan ahead. Transportation plans were also worked out at this meeting. At the close of the meeting, the care coordinator ensured to take all of the information discussed back to Melanie's clinician at Spectrum Outpatient so that that treatment center would also continue to support all of Melanie's medical needs. So that was wonderful. Prior to working in this community-based program, it was almost unheard of for doctors or specialists to set aside time and attend these care team meetings to support their patients. So this is really progressive. It was wonderful to have this example on our team, and this patient really benefited from this type of communication.
And I think it really shows the benefit of that care coordination and getting team members to talk to each other, right? Which is really filling in those gaps so we're not treating in isolation. And so now we welcome either cases, examples, things to discuss, what have you encountered with substance use disorders that we could be helpful to? And also, I'll take a look at the question and answers that may have come in thus far. We've got just a couple. And so I will, respond to those. Right. And so the open cases is just a comment. So I appreciate that comment quite a bit. So I'll share it of an individual who's been receiving certification for Psych NP. Yay, we need more of you. And taking the Mass and New Hampshire boards to get that advanced practice license. And so you're right, there is such a huge shortage. I just really wanted to recognize that and appreciate your moving forward in your education, right? Taking this period of time in our lives and turning it into something unbelievably supportive to our community. So thank you for doing that. It is a long process and we need more people to do it. So, feel free to reach out if you need support on that supervising psychiatrist. Maybe we could partner on that. But there is also another question about what if a patient in need has no health insurance? So that's a really great question. So the case management services, the care coordination service that Rachel talked about is a Massachusetts Medicaid service. And so often are a lot of those case management services, right? We are fortunate in Massachusetts, and I know that this varies significantly by state, where we do have funding as substance use treatment providers through the Department of Public Health. And so if somebody is uninsured, and we know that our patients are overrepresented in the uninsured category, despite the kind of universal access that Massachusetts has become known for, it's our people who are not insured, right? And so we actually have rapid access connections to sign individuals up for insurance, but also are able to provide these needed substance use services with funding through the Department of Public Health. And so I know that varies by state, kind of what level of support that the State Department of Public Health can support. And so, but that's what we're able to do. And let's see. So we have another feedback on a big fan of recovery coaching, but recently when offered this to their patients, they decline and say they don't need it. Any suggestions on good ways to leave them this info for the future? So I think, and Rachel, you feel free to jump in on our experience in the CP, because we do have such a wonderful peer and recovery coach in the CP. But in general, all of these steps are challenging for somebody, right? Change is really challenging, but being connected to a peer, a lot of that might have a lot to do with fear of judgment, right? Fear of being judged by a peer who is in recovery for where they are at. And so kind of normalizing those concerns, right? And really just saying, well, unless you talk to this person, like, you might not know if it can be helpful. So just getting somebody to agree to maybe a brief meeting, a brief phone call, right? And give that connection to a peer a chance. And then if it's still not for them, they can walk away from it, right? It's a voluntary service, but most people, once they find they've gotten a connection with a peer, see that as value that is not replaced in any way in any other place in the treatment system. I don't know if you'd have anything to add to that, Rachel.
Yeah, just what we do in our program is when we identify that someone has a substance use disorder, the care coordinator will just tell them, well, as part of our care team, we have a peer recovery on staff who will just be reaching out to you to introduce himself. So he calls pretty much anybody and everyone that has a substance use disorder. Some people pick up the call and are willing to speak with him. Other times he just leaves a message to say, hi, I'm Joe. I'm calling to let you know I'm the peer recovery person on our team. If you ever need anything, here's my phone number. Please feel free to reach out to me at any time. So we just actively have him introduce himself to folks who identify as having a substance use disorder. Sometimes the idea of it, as Lisa mentioned, might be a little scary, but when they hear his voice, he's so welcoming and friendly, and obviously is a peer. So he's using the right terminology with folks, whether it's on the phone or leaving the voicemail, that he does have some success with folks reaching out to him, and he's able to support a lot of our people.
Yeah. And so the next question is that speaking of services of Medicaid patients and what's available for Medicare. And so, it depends on your region, but, for concurrent Medicare and Medicaid in Massachusetts, there's OneCare, which can provide some similar support we can connect individuals to. But I'm happy to report there have been some changes in Medicare related to payment for substance use treatment. One of the challenges we have at those levels of care I talked about is that Medicare still only pays for a level 4.0 detox, which is really more of a hospital level, medically, kind of heavily, intensely medically supervised detox, which honestly most people don't need, and does not pay for a level 3.7 kind of more community behavioral health provider detox. But there are some of those, in New England that people can access through hospital systems. But really recently, it'll be, I think, a year in January that Medicare has started for the very first time paying for methadone treatment. And that is not something historically that Medicare has paid for, and is really a big shift in the field. So accessibility, even nationally, for individuals with Medicare is starting to change. Let's see, but outpatient counseling, all of those things are often typically available for Medicare patients as well. So data on the success rate of recovery with use of a recovery coach, that's a tough one, right? And I'll be the first one to say, right, that data for outcomes for addiction is a hard thing to document, right? It's very different than medical data on, where kind of returning to the hospital is really a bad thing, but that chronic disease nature of addiction, sometimes that returning to an inpatient setting is not a bad thing in addiction. So it's tough to measure outcomes. And so similarly, recovery coaching is being adopted in really varied ways, nationally and locally. And often it's a piece of somebody's recovery plan, right? So we don't really measure if somebody has just recovery coaching, here are their outcomes, because often they're a member of a broader care team where somebody might be receiving medication treatment and have a recovery coach, might have gone to residential and then finished with a recovery coach. So it's kind of hard to say what success rate of recovery coaching is. I can tell you qualitatively, I hear from patients all the time that that connection to peers makes a difference in their long-term recovery path. And so begin to access recovery support navigators. Those are in Massachusetts, those are based in outpatient centers most often. So starting with kind of your local outpatient program, and seeing if they have a recovery support navigator that you can connect someone to. Rachel, I'll let you answer the question on what Mass Health program does someone need to be on to access the community partner BHPMW.
Yeah, so we work with 11 ACOs, accountable care organizations. So Mass Health is the overarching umbrella, and Mass Health has 11 different companies contracted with it. So there's things like Steward, Reliant, Tufts, BMC, if you're familiar with the Massachusetts ACOs. They have to be under an ACO in order to qualify for our program, because we're also trying to do business directly with these identified payers. And we're basically showing them that we can decrease cost and improve outcome for their patients. We're trying to keep them out of the ED, like we were saying, and connect them to PCPs, therapists, recovery coaches, anything that could really support a more appropriate, stable level of care for these folks. But yes, they have to be on Medicaid, Mass Health Medicaid, and they need to fall under one of the accountable care organizations.
But this model is being adopted broadly in other ways. And so there's other kind of care coordination, organizations that are coming in and buying that service, maybe for like a commercial population. I mean, I think we're starting to learn from this experience in healthcare transformation to see how valuable this kind of outreach and engagement of a care coordinator and care coordination service can be. So I think we'll start to see it more widely adopted kind of across payers and across systems. And thank you, Cheryl, for that feedback, right? And I would agree, right? Those who say on Weight Watchers, those who come to meetings lose more weight, right? And I would agree with that with recovery coaching, right? I always say that everybody has an individual recovery path, and there's lots of pieces on that path, right? It's not just one treatment lane, or if I try methadone treatment, that's going to be my lane. It could be methadone treatment plus fitness and exercise, plus peer recovery coaching, plus spirituality, right? Like there's all kinds of things that come together for somebody's recovery path. All right, it looks like we have about 5 minutes left. I'm just going to quickly look at a couple of the slides we have to wrap up. Just noting, just so that you're aware, the Case Management Society of America has an opiate use disorder case management guide. So it's from 2018, but there's still some really wonderful information there. If folks need support with education training, that certainly people can contact me. But there's also some online training through the CMSNE for kind of further learning. You'll have access to these slides, but these are the references. I won't go over them, in detail, but just to let folks know kind of what services we're coming from, as Spectrum as a nonprofit. And so what I might try to do is share the 3-minute video that Kathy was trying to share at the beginning. So give me 1 second to upload it, if that's okay, Maureen or Tammy.
That's fine. I have it uploaded too.
Oh, good. So if I have any trouble, then you can certainly support me in that.
Absolutely.
All right, so I think I need to back it up because you know what, I might have you do it just because it's only starting from where she left off, and I don't know why.
Okay, I have it in my next slides for the break to play. So we're all set.
All right, great. Thank you so much. We really appreciate the interaction. There were some, you know, some wonderful kind of questions and feedback, and thank you for having us.
Thank you, everyone.
Well, thank you, Lisa and Rachel, both for your presentation.